Now we move on to hormones that control all of the organs. So we'll talk about endocrine manifestations of ECD. This is going to be given by Dr. Alexandra Dodd, who's an assistant professor in endocrinology, diabetes, and metabolism at UAB, and has been a great partner in our histiocytosis program, evaluation and care for patients with ECD and beyond. So please give her a warm welcome.
Okay, awesome. All right. Thank you, everyone, for having me today. I'm very excited to be here. And so, as Dr. Royal mentioned, so I'm an endocrinologist here at UAB. And, in case you didn't already know, endocrinology, it's the study of like hormone disorders. And so I think if I was to change my title, I could make it more catchy and say ECD and your hormones. So, all right. And, okay, sorry. All right, there we go, I'll stand over here. All right, so just kind of the outline of my talk today, I'm going to first just give an overview of the pituitary gland, which is the main organ that's affected in ECD in terms of endocrinology. I'm going to give an overview of endocrinology disorders in ECD, and then also go how we diagnose hypopituitarism and how we treat it. And so just to give you a brief overview of the pituitary anatomy. So the pituitary gland is a little gland in the brain. It's about like a centimeter, maybe a little bit smaller. It's kind of like between the eyes, kind of behind the sinuses. And it sits right here in this little, so there's like the nose. So, and it sits in this little groove in the bone called the sella turcica, which is Latin for Turkish saddle. And it sits sort of below, there's this place called the optic chiasm, which is part where like optic nerves meet, and optic nerves is what controls vision. And then it sits below this part of the brain called the hypothalamus. And then it connects down, and it's divided into two parts. There's the anterior, or the you can think of it the front part of the gland, and there's also the posterior, or you can think of it like the back of the gland. And the posterior pituitary is actually technically a connection, a continuation of the hypothalamus. And so I know this is a very busy slide. You don't have to go all over this in detail, but essentially it's just to illustrate how these parts of the brain are connected. So generally the pathway is, so the hypothalamus, which I said is above the pituitary, will make some kind of a hormone which acts on the pituitary gland to tell it to make another hormone. And then the pituitary will make a hormone that acts on the actual target gland. So if we use cortisol as an example, the hypothalamus will make a hormone called CRH, or cortisol-releasing hormone. That acts on these corticotroph cells in the pituitary to make a hormone called ACTH. And that acts down on your adrenal glands, which sit on top of your kidneys, to make cortisol. And so there's a similar pathway between the thyroid. The hypothalamus makes TRH, which acts on these cells in the pituitary to make TSH, or thyroid-stimulating hormone, and that acts on your thyroid gland in your neck to make the thyroid hormone, which we measure as T4 and T3. So it's just kind of illustrating that connection between everything. So the pituitary makes a lot of hormones, especially most of them are coming from your anterior pituitary. So just to kind of go over what these hormones do. So ACTH, it stands for adrenocorticotropic hormone. That is what acts on your adrenal glands, which sit right on top of your kidneys. And the big hormone that promotes is cortisol. So cortisol, it's known as the stress hormone, but it is essential for life, and it regulates things like blood pressure, blood sugar. And then below that you have the thyroid-stimulating hormone, TSH, and so that acts on your thyroid gland in your neck to make thyroid hormone, which we often measure as T4 and T3. And thyroid does a lot in the body, especially regulating metabolism, heart rate, and a lot of things. And then the FSH and the LH, they're kind of what we classify the gonadotropins, so they're really involved with like estrogen, testosterone. So specifically, FSH in women helps promote estrogen production, and in men, it tells the testes to make sperm. And then luteinizing hormone, or LH. In women, it promotes ovulation and also leads to progesterone production. And then in men, this is the hormone that promotes testosterone production. And then growth hormone, this is, as the name suggests, helps with growth. So acts on bone, muscle, fat, number of other organs. So really, this is like in kids, this is what helps kids grow tall. And it also regulates things like muscle mass, fat mass, and as I said, most important in kids. There's also a hormone called prolactin, and this acts on breast tissue in women and helps promote lactation and breastfeeding. And then the posterior pituitary, that's, like I said, the back of the gland. The most hormone that really, we talk about in ECD is antidiuretic hormone. Also, it's called arginine vasopressin. This hormone acts on the kidneys and helps the kidneys retain water. And then it also makes a hormone called oxytocin, and that acts on the uterus and the breast. And so in pregnant women, like who are in labor, it's what promotes uterine contraction. So especially some women, if you're on the labor and delivery ward, sometimes the doctors will give oxytocin infusions to just kind of help the labor progress. And then it also helps promote like milk letdown, and it's also kind of known in bonding, and sometimes it's been known as the cuddle hormone. But essentially, those are the main hormones. And this, again, it just illustrates how just this teeny tiny little gland up in the brain really just kind of affects, all parts of the body. So really appreciate what this little gland can do. All right, and so as far as endocrine disorders in ECD, so it can be seen in nearly 50 to 60% of cases, and pituitary involvement is common with up to 58% having at least one hormone deficiency. So arginine vasopressin deficiency, or AVPD, is often the first endocrine manifestation to present and may be seen in around 30% of patients. And sometimes you can have that disease without even having any kind of visual changes on your imaging yet. And then growth hormone deficiencies considered the most common anterior pituitary hormone deficiency. And then sometimes ECD can even infiltrate organs directly outside the pituitary, including the adrenal glands or like testes. And so these are just some MRI images of a patient with ECD. And so generally some changes that you can see on an MRI. So in a normal pituitary, there's this little, so like I said, the posterior pituitary has what's called like little bright spots, so it looks white. And a lot of times that spot can be absent in ECD because especially if they have DI. And then you can also get enlargement of the pituitary stalk, so kind of like right here, that it can just appear thicker on the imaging. And so, as far as this is a breakdown of what's kind of the frequency of these hormone deficiencies. So, like I said, so AVPD around 30% or so. You can see, so growth hormone deficiency up to about 80% or 78%. And then you can also get deficiencies of low cortisol, like I said, low estrogen, testosterone, hypothyroidism. And like I said, you can also sometimes get direct infiltration of the adrenal glands or testes. You can also see reduced bone density, and then also diabetes mellitus. And again, not to be confused with diabetes insipidus. I'll go into that in more detail. You can think of that as just high blood sugar. All right, so again, these are just kind of the deficiencies I'm going to kind of go into a little bit more depth. Okay, so arginine vasopressin deficiency, AVPD, a lot of us, it's a relatively kind of new term. I think, for years and years, everybody called it diabetes insipidus or DI. And this term came from, so diabetes insipidus literally means tasteless urine in Latin. And then also diabetes mellitus means sweet urine in Latin. So some doctor way back in ancient times actually tasted people's urine and figured this out. So that's actually where those terms came from. And the key thing here is, so AVPD, stands for deficiencies. So and that's where that posterior pituitary is not making enough of that hormone. And the main symptom is just people, they just can't concentrate their urine, so they just pee all the time, nonstop. It's very clear, dilute urine, and they're usually just chugging fluids like nonstop just to keep up with how much they're urinating. And then there's also, again, this isn't what we see in ECD, but there's also people who can get resistance to that hormone at the level of the kidneys, and so similar, they can't concentrate their urine. But again, that's kind of more of a kidney thing, and not really the type that we see here in ECD. But the main, probably the most concerning thing that we have to watch out for is if you get too dehydrated, your sodium level can go up. We call it hypernatremia. And it can be, if it gets severe enough, it land you in the hospital. So really have to be careful with that. And most patients, like even if, there's treatments, if you can stay enough, if you follow thirst and drink enough water, you can keep your sodium normal, but it can be very dangerous. And so really, how do we diagnose this? So it's kind of mostly just the symptoms of like peeing a lot, is very dilute urine. Sometimes you can also do what's called a water deprivation test, where you just restrict water and see how the sodium and the urine output changes. There's also this blood test called a copeptin level. It's kind of a marker of that hormone in the pituitary, and it's usually low in people who have AVPD. And then treatment, at least, like I said, we do have good treatments for it. It's a medicine called desmopressin, or DDAVP. It's available as a pill, but you can also, it comes in a nasal spray, or you can do it as a shot under the skin or through the IV. Usually pills are the easiest choice, but sometimes if they're requiring really high doses of the pills, sometimes it's helpful to switch to a nasal spray because it's just more potent, so they don't have to take as many pills. And really just the goal with this is to make sure we just kind of get that urination down to a normal level, and also just usually especially trying to control symptoms at night, so you're not waking up 10 times a night to use the bathroom. And really just monitoring is just how much you're urinating and watching sodium levels on labs. All right, and then so hypogonadism, that's a term again just for low testosterone or low estrogen. And just from a definition standpoint, it's considered primary if the defect is at the level of the ovaries or the testes. And it's considered secondary if it's caused by those decreased FSH and LH hormones by that pituitary. So in women, symptoms can include just loss of menstrual cycles, infertility, vaginal dryness, decreased libido, or osteoporosis. And in men, similar, can be caused decreased libido, erectile dysfunction, or infertility due to low sperm counts. Also osteoporosis, and that's just because estrogen and testosterone are important for bone health. And diagnosis is just the lab, so low levels of those hormones, and then the FSH and the LH are helpful in distinguishing between whether it's primary or secondary. Treatment, so in men, it's just give testosterone. You can do it as shots, like under the muscle or under the skin, or there's even like a gel you can rub on the skin daily, or there's even some pills. I will just say, especially if it's a young man who's still hoping to have kids, from a fertility standpoint, you actually don't want to give testosterone directly because that can decrease sperm production even more. So there's actually some other meds like HCG that can help preserve that sperm production if needed. And then in women, it's just estrogen, and there's either pills or patches. And then if a woman still has a uterus, you do have to give some kind of progesterone to go with it to prevent that uterus lining from getting too thick. So growth hormone deficiency. So as I mentioned, in kids, if this is deficient, it's going to cause stunted growth. In adults, it's less, the symptoms aren't quite as obvious. It's more things like fatigue, maybe an increase in fat mass, decreased muscle mass, and then some potential slight increase in cardiovascular risk factors, fatty liver. And really, adults can survive with growth hormone deficiency. It's like I said, and then as far as how do we measure it, so you can measure a growth hormone level directly on blood work, but actually since it's it fluctuates so much throughout a 24-hour period, it's actually better to check something called an IGF-1 level. It's a hormone made in the liver. It's a little bit more steady day to day. So that's kind of the main biomarker that we follow in the blood work. And then generally to diagnose growth hormone deficiency, you have if you have a low IGF-1 and 3 other hormone deficiencies, so let's say you have the diabetes insipidus, low testosterone, and low thyroid, bam, you're done. Insurance, you can start treatment. If you have low IGF-1 with less than 3, you usually have to do a growth hormone stimulation test and fail it. So there's a couple different tests out there. The main one that we use at UAB, it's one called glucagon. It's kind of lengthy, but it's a boring test. It's 4 hours. You get a shot of a medicine called glucagon, and then we just measure growth hormone levels over those couple hours. And then there's another one called masmorelin, which is just an oral. It's a little bit shorter test. Unfortunately, it's not available in the U.S. right now. And then there's also one called the insulin tolerance test. It's an older one. It's kind of fallen out of favor because, essentially you give insulin to lower someone's blood sugar to almost like a dangerous level, and then you measure growth hormone levels, but like I said, it's very dangerous. We just don't really use that one anymore. As far as treatment, so growth hormone, it's available as a shot under the skin, so like either as a daily or now there's even some once-a-week options available. And then monitoring, it's going to be your the IGF-1 level, just metabolic parameters like bone density, things like that, and then just are you having any benefit from it? As far as for the thyroid, so again, the definition is just decreased thyroid level. Similar, if you're catching a theme here, it's primary if it's actual level of defect at the thyroid itself, or secondary if it's from that pituitary not making enough TSH. Symptoms, so it can be fatigue, weight gain, feeling really cold all the time, constipation, dry skin, hair loss, abnormal menstrual cycles, depression. And as far as treatment, so usually levothyroxine is considered the first line, and there's generic or even several brand name options out there. As far as monitoring, if there's any concern for like pituitary dysfunction, the free T4 is actually going to be your best lab test here, and we usually like that to be somewhere in the mid to upper range of normal. So TSH for people who have a normal pituitary is usually good, but as I said, it becomes unreliable if that production is down. So I see this a lot, like if I have a pituitary patient with seeing a primary care doctor and like, I'm going to check your TSH. Oh, it looks normal or it's low. Then they may not get the treatment they need. So I really go by this T4. And then just a comment is some people will use like biotin supplements for hair loss. That biotin can just mess with those hormone labs, so that if you do take biotin, it's best to hold it at least 3 to 5 days, or better just don't take it. So it's not that biotin is dangerous in and of itself, but it just messes with those labs. So adrenal insufficiency, same thing. So if it's primary level of the adrenal glands, secondary if it's caused by pituitary dysfunction. These symptoms can include fatigue, low blood pressure, nausea, weight loss, passing out. This one, again, can be dangerous if it's left untreated. So diagnosis, you can either just check a morning cortisol or you can do a cortisol stimulation test. And then treatment, so it's going to be steroids, and specifically the treatments are usually our go-to ones are going to be hydrocortisone or prednisone, but these are going to be much lower doses. So if you've ever gotten a steroid for a sinus infection or something, these are usually much higher than the doses that we use for treatment of adrenal insufficiency. And the reason being is, you don't want to overdo it because then you can cause things like, weight gain, diabetes, things like that. So, and then if you do have adrenal insufficiency, if you're ever getting like a surgical procedure or any kind of like a major stress, or you're sick for some reason, sometimes you have to take like an extra what we call a stress dose. And then sometimes on labs you can see mild prolactin elevations. This is usually due to something called stalk effect, where this dopamine that usually is kind of like the brakes for prolactin is impaired. Usually you don't really have to treat this, but sometimes high prolactin can cause like menstrual cycle problems or infertility or actually lactation, and there are some meds that we can give called like cabergoline. They're actually pretty effective to help with that. And then diabetes mellitus, again, not to be confused with diabetes insipidus. This is just high blood sugars, and kind of best treatments for this is usually lifestyle measures. So try to cut back on the carbs, the sweets, If you're if you're overweight, losing weight, exercise. There's also a lot of meds out there, like metformin or some of the GLP-1s you may have heard all about that are all pretty effective, and many others. And this type 1 diabetes that's different, where it's caused by essentially it's an autoimmune destruction of your pancreas, so you can't make insulin anymore, and these patients have to take insulin. So, but anyway, the key thing is just watch your blood sugar, and there you can also take an A1C. So in summary, ECD can be associated with a number of endocrine disorders, most commonly involving the pituitary gland. And then, like I said, central DI or AVPD, it can be the first hormone deficiency, and it's presented with high urine output, and so the treatment for that is DDAVP. And then essentially, it's good to get a full pituitary hormone evaluation at least once, just to screen for any kind of other hormone deficiencies that can be treated. So, all right, these are my sources, and I'll be happy to take any questions.